Are we on? We're on. Okay. All right. Well, welcome back, everybody. We've got a big group here to discuss the kind of hot off the press workshop, improving transparency and developing sustainable neonatologist staffing models. Now, this is a very hot topic, obviously, in the community. So you guys are coming from all over the country. I'll let you introduce yourselves and tell us where you're coming from, and then we really just want to hear about the lessons learned.
Kerri Machut, Lurie Children's, Chicago.
I'm Chris Bishop. I'm at Children's Hospital of Pittsburgh.
Milenka Cuevas-Guaman. I'm from Houston, Texas Children's.
And Steve Olsen from Children's Mercy, Kansas City.
Okay. Well, this has been a buzz, really, I'd say, in the last 5 years, but certainly I think through the pandemic, I think people are really trying to reevaluate what does work-life balance look for them, and what does work-life balance look for a group or a practice or a unit. So every day every week I feel like somebody's asking the question on social media or through interactive platforms. So what did you guys tackle in the workshop today?
Well, we tried to do several things. I think when we think about staffing and the issues that are really with current state, a lot of it is around transparency. Yeah. So that was the first thing that we really tried to address. There are a few published models out there. However, there's a lot of variability. That's the other big threat to this. And so Steve and I both walked through our center's examples of how we kind of plan and strategize to handle staffing, and when we talk about clinical FTEs or full-time equivalents. So that was kind of the first part of the workshop. Everybody had an exercise to be able to calculate their own FTE using the Lurie and Mercy models as examples.
So can you tell us a little bit about what that variability looks like? What you were saying the current state. So what is the situation people are finding themselves in?
I think with variability, there's a lot of different types of variability too. So I think center to center, people are thinking about this in a lot of different ways. Some of them more officially, some of them less officially. I think different centers calculate clinical time in different ways. Some people use an hours model. Some people use a weeks per year model. Some people do count call into their clinical time. Some people don't. Some people adjust for different factors. So there's a lot of that happens, and it really hampers us as a field across the country because we can't advocate collectively for some of the changes that we're hoping to. There's also a variability in how things are done between neonatology and other aligned fields. So critical care, cardiac intensivist, emergency medicine, even how those fields work through staffing and what they project as their hours or clinical needs are actually often quite variable from how neonatology is expected to work.
And so some of that is that, say, an FTE in emergency medicine maybe significantly less hours than an FTE in
28
neonatology.
to 32 hours per week. Clinical hours is the standard for emergency medicine.
For full FTE.
Correct.
Okay, and what about our colleagues in the PICU?
It goes back to it's very variable, and some PICUs belong to departments of pediatrics, some belong to other departments, but overall it seems like it is less, and it's with different offsets and call models and things that seem to be a little bit more amenable to sustainable and work-life balance.
There was an AMSPDEC paper that came out earlier this year. I think Klein was the lead author in Journal Pediatrics that did look at the median hours. And so for 0.8 clinical FTE, which is typically standard, for neonatology it was over 1,600. And I believe for those other fields it was typically less than, it was like in the 1,200 to 1,400 hour per year range.
And I'm recalling that there's often a big difference between the pediatric work hours and our adult colleagues. Why do you guys think that is?
Money. Just to be honest, it's reimbursed. It's multifactorial, clearly, but a lot of it has to do with reimbursement, how reimbursement is set up, and how work is valued and paid for.
Yeah, we still, pediatrics still seen as small because they're kids.
Yeah.
And that even goes farther to neonatology, your babies. Even At some point, I remember hearing this anecdote when they were building a new NICU, like, why do you need a big bed?
That's right.
Why do you need this big room? I mean, and then you are forgetting that it's just not the baby, right? And the size that it matters for the room and what that room needs to have. But that's what people think outside.
You know, I think about two different challenges with neonatology. One is historically, we used to work hundreds of hours a week, you know, when it comes down to it. And because the neonatologist was not in-house for call, they would round, go back to their offices, do all their research in the afternoon. And so the RVU benchmarks and all of those hour benchmarks got way out of proportion to what we're doing now. The other challenge is, does 1 hour equal 1 hour? Does 1 hour in a level 4 equal 1 hour in a level 3 or level 2? If you're on, you know, home call versus in-house call, it's all an hour, but are they equal?
And of course, and you guys are tackling this also when you did your FTE calculations with the group, that our non-clinical duties seem to be growing, right? We're doing just as much or more in the unit, but we're having a lot of other non-clinical duties. Look, can you talk a little bit about what that looks like? What are those non-clinical duties that people should be thinking, gosh, this should be part of my FTE?
Yeah, you know, the workshop that we just did with the attendees to this meeting, that was the second part of it. We really wanted to get feedback from them. We did some surveying that we'll be able to use for data for future decision making and publications. And so those were the questions that we were asking. You know, what are the things that, and we asked our attendees to tackle that in, you know, like 10, 15 minutes, which is really, like, here's the
Solve the
question.
problems of neonatology in 15
That's right.
minutes.
Yeah, and you know what, they rose to the occasion, right? They were really thoughtful, and we had a great groups and mixes of people, and what it really comes down to is people, now there's new promotion pathways, right? And people are doing all these different things, and we're still only giving offsets for very traditional things. And so when the groups, you know, that tackled that question brought up a lot of the things that are actually part of promotable pathways, like QI or leadership things and things like that. And so, you know, coming to a consensus on that and talking about what might need to be reimbursed or what we think should have offsets is one piece of it. And there are things that I think that many of us think would be very reasonable, like being a unit director, program director. Theirs is already, fellowship program director, theirs is already determined. But some of these other things, but then making the leap to how do we make that happen is you know, really going to be the important next step.
But that also comes back to the variability. So, for instance, the role of a CHNC, since we're here, of a site leader, that's a role within the organization that every center then has, and some centers give protected time for that and others don't. And in the end, it impacts ability to be productive academically, ability to focus clinically when you are working and having to straddle those things, and ultimately really your joy and satisfaction with your career. And those types of things, if they're not adequately addressed, really will get to sustainability issues for our field.
Did you guys talk about how some of these things, like, say, being a site leader for the CHNC, brings value to the unit and the hospital, and how we should be advocating for protected time?
Go ahead.
I think we all don't have to be convinced that it brings value.
Sure.
The question is, who else do we have
That's
to
right.
convince that it brings value?
And how do we fund it? Because again, like Chris mentioned, it all comes back to money. And one thing we weren't able to really get to, because the workshop really was a lot of fun. There was a lot of interest, a lot of value. I think people that really took away from it. But one thing we hinted at in the closing was, how do all of these workforce characteristics and metrics actually matter to clinical outcomes? Yeah. And if we could better demonstrate that link, that's where we might be able to really prove the value. Like if we have, say, better continuity of care, does that actually lead to shorter lengths of stay and translate into something that's more fundable? Or punchline is actually, so far no data has shown that, just to say, because I did do a study on that. But these are all the things that I think really could have potential impact. If the workforce is healthier, hopefully it turns into our babies also being healthier and our science being healthier and more robust.
Was anybody surprised by their FTE calculation?
I think yes. I think there were
It also
lots of
was,
people,
it's complex, and it was hard for both Steve and I in the limited time that we had to really walk people through it. There were a lot of questions, a lot of head scratching, a lot of why do you do it this way, and it's confusing, but I think also, yes, surprising.
But I think what it come out from that, or at least what I think they took, is that it has to be done, right? Like, I mean, are you going to put more value in your unit? Value to level 4 or value to level 2, or why you do those difference, and then at the end, then it'll be more equitable between everybody, right?
One of the common themes was how do we define these things, and it may be that we define certain big picture ideas for everyone, and that at an institutional level or a more local level, it needs to be defined more specifically for that place. And then we talked about that it's important to have flexibility. You know, important to say, well, we've done this way for the past 10 years, and even though we've added 4 new hospitals and, you know, an entire group of APPs, and we don't have any more residents or something like that, you have to have that flexibility also. But getting those big picture concepts, some sort of agreement on that is I think really where we're going to be able to affect change.
And so, for units who are struggling with this, which many of us are, you're really advocating for it. It doesn't matter necessarily how you weight certain things, but that everybody's doing it the same way and gets the same credit for doing different things in the unit. Is that right?
Yes, I mean, you as a division, you'll know what has more value, or or costs more points, whatever you want to call it, or more hours to dedicated units or dedicated roles. Because we don't know, right? Like, maybe you are also like a front lab provider. If you don't have APPs, and you are going to be able to see less, right? And other units are going to be able to see more.
Let's get a little closer.
Oh, so sorry. So I think everybody has to figure out in their role what it means, but we still should have a target. Like, it doesn't mean that you're going to go 365 days.
The first step is really just making sure that you're counting. The second step will be reducing the variability in how we count. But I think if we could just make sure that people are thinking through their systems and they are at least accrediting these things or counting these different roles, that's the first step for a system that might be struggling.
I think the only thing I was going to add is none of us are independent, solitary neonatologists. We're all part of a group. And if we can improve the overall health and well-being of our group, we're all going to be better.
Yeah, totally agree. So I've had the opportunity to talk with some of you on this topic before, so I know the answer. But for the listeners, do you think that there is a role for standardizing staffing models on a national level?
I do. I mean, that's what I was kind of trying to hint at. And so, again, there are a lot of groups working on this. So the 3 of us are working with a team, Christiana Dahmen and Emily Miller. We have a grant through the AAP with many advisors, one of whom is Steve, that help us. And we're putting together a summit to try to decrease some of this variability and advocate for some of that national collaboration and standardization that you're thinking of, as well as the SWAN group, of which Steve and I are a member. That's a group of division directors primarily. I'm not a division director, but that is also trying to solve this issue.
And I see you have a very interesting survey here for the group.
Do you want to try to answer?
What is Daphne and Ben? What do you think?
I'm not going to answer. But were there any interesting discussions on any particular, I'm sure there was, but any questions that stood out that were really a point of discussion?
We're all flipping.
This was a great idea that Chris and Milenka had, so they should speak about it. But it was part of our grant, and we did part of that grant funds some data collection. We're doing interviews and qualitative analysis.
So I'll go with the one that I remember the most. It was question number 5, which was what is the maximum number of consecutive in-hospital hours a neonatologist should do in level 3, level 4. I was surprised to find that a lot of people are still okay with 25 to 30 hours consecutively.
Yeah.
Right.
Especially given the data on, increased mistakes with prolonged calls, especially those overnight calls, more car accidents, worse health outcomes for physicians who do those prolonged calls.
Yes, and also because we asked them to think about the ideal. So
Right.
I really don't, what you're
It's
doing
what
right
they would
now.
pick.
Yeah,
They were
exactly.
picking it.
So,
Okay.
there still continues to be that ideal.
Which feeds into another question, which I think is interesting. Should a neonatologist take in-house night call while on service and then round post-call? And people asked for clarification of the question. Does that mean like round and leave? Does that mean round and then stay
Because
there
if you're
till
on
5 or
service, you
6
may stay
p.m.?
all day.
Right, like how and we just said, please just like look at just whatever the question reads, whatever that means to you. And there were a good portion of people that said it depends. And that probably speaks to a lot of things. It probably speaks to knowing that if you don't round post call when you're on service, then people thinking all my in-house call will then be when I'm not on service, which will then completely interrupt potentially the times that I'm working on my academic things or the other things. And so we have a system that it already lends itself to certain things. We had primarily mid-career folks. We had it was almost like a bell curve of early career to mid-career and late career, and so you have people who have been practicing and in the system for a while. And I think a really interesting question to think about is sort of at the other ends of the bell curve, the folks that are saying, I just don't even want to take call anymore because health-wise, for health reasons, or the new grads who are coming in and saying, I have never worked 36 hours straight before. I've never had to
I don't want to
post-call,
start doing that now.
right? And like, why am I going to get a job where I have to do that? Yeah. So I think those are really interesting things that we have to consider.
And she had put in a free text word cloud question towards the end of what's the greatest challenge to staffing in neonatology. And a big one was generational tension, which I thought was really insightful.
Tell
and
us
certainly
more.
I think, well, this is part of the live poll, so it was just kind of a quick, there weren't discussion points around that because this is the data that, again, under IRB protection, we're collecting towards publication. But the concept there, I think, is that there are different generational beliefs about work-life balance or personal-professional life balance. And there's also different generational needs, right? So not only does maybe the older neonatologist not want to work overnight anymore, but also a young mother who's nursing doesn't want to do that either. And so there's just different needs for different folks.
And I think it also comes back to flexibility. Because if we say everybody has to work 7 weeks and everybody has to do 3 24-hour calls, whatever that means, then there's no flexibility in the system. Then how are you going to have part-time people, right, or accommodate for health reasons? So we need to be thinking outside the box, and we need to be also going with where neonatology is going. It's getting more complex. More things are falling on the attending. Right? For many reasons. I mean, we could talk about the reasons, but it's how to create sustainability from now on. Mm-hmm. If we don't deal with that now, we don't know where our career is going. That's right. And it's really not for us. We might have 20 more years, but
For the incoming
generations.
Yeah. And the babies.
And the
babies,
yeah,
and
right.
the units and the families, and making sure that we're taking care of our patients.
I have 2 questions. My second to last question is, are there any resources for people who are interested in learning more about staffing models as it stands?
Yes, so there are quite a growing number of publications on this topic. Our group has written on this. The SWAN group is working on a manuscript for that now. So if you put it in, through PubMed, I think when we did the podcast with you earlier, we did put some of those resources collected so they would be referenced on that.
Page.
There's been
That's
a few more that have come out this summer that are also good to add to that. And that's pretty much where things live at the current state.
And when can we expect the data of the collection you're doing now?
Well, so we are analyzing right now, and hopefully we'll get the publication out by January, February. That's kind of our goal.
Okay.
And sooner, maybe sooner. But then I think the other big step is the summit. And so the summit will be in June. And hopefully from that, we can give you better tools. Obviously, it's still advocacy tools. Right? We're not going to solve the problem, but hopefully we can give you better tools so you can talk to your higher-ups, whatever that means in your place.
Any closing thoughts?
I think people just need to keep thinking about this and talking about it at their own institution and supporting transparency about these things, helping our incoming recent grad junior colleagues understand these concepts so that they can ask the right questions and figure out what they want and as they're looking for jobs so that they can sort of speak this language and go in with their eyes wide open. So I think to all the listeners out there, like just educating yourself about it and starting the conversation at your own institution is a great place to start.
And I think for us, since this goes not just probably to neonatologists, is how do we recruit the next generation? And so talking about this out loud and in simple terms, and it might get us actually recruitment of more people and more ideas, and that's what we need to keep doing.
Well, Kerri, Steve, Milenka, and Christine, thank you so much for your advocacy, and we're really looking forward to seeing the publication.
Awesome. Thanks for having us.
you.
Thanks, everybody.
Thank you.